Hello, I am Dr. WAFAEY BADAWY. I'll be talking about gestational trophoblastic diseases, Part 2. Modified WHO classification of gestational trophoblastic disease. Hydatidform moles, abnormally formed placentas, including complete hydatidform mole, partial hydatidform mole, invasive mole, gestational trophoblastic neoplasms, including choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor, trophoblastic tumor-like lesions. These are benign lesions, including exaggerated placental site nodule or blood, unclassified trophoblastic lesions, abnormal non-molar villus lesions. Coriocarcinoma. Definition and general background. Coriocarcinoma is a highly aggressive form of gestational trophoblastic neoplasia. If untreated, it is composed of syncytial trophoblast, cytotrophoblast, and intermediate trophoblast. That is a trimorphic neoplasm. Coriocarcinoma in the USA complicate only about 1 to 25,000 pregnancies. However, the incidence is 20 to 40 times higher in Asia, Africa, and Latin America. Coriocarcinoma can be gestational, originating from a pregnancy, normal or abnormal, or non-gestational. Complete hydatidform mole is the major predisposing factor, and about half of the cases of choriocarcinoma follow a complete hydatidform mole. Approximately 1/4 of gestational choriocarcinomas follow abortions, and the remainder occur after or during normal pregnancies, or rarely within an ectopic gestation. Non-gestational choriocarcinoma includes those of germ cell origin metastatic to the uterus, and endometrial adenocarcinomas with trophoblastic differentiation. It occurs most commonly in the uterus, fallopian tubes, and ovary. After ectopic pregnancies are less common sites. Intraplacental choriocarcinoma can occur after non-molar pregnancies, usually in the third trimester or postpartum. It occurs in the reproductive period with an average age of 29 years. Rarely, choriocarcinoma may be found in a postmenopausal patients. In such cases, the tumor may represent a gestational choriocarcinoma with a long latent period, or it may represent somatic carcinoma with choriocarcinomatous transformation. Typically, the patient with the choriocarcinoma has markedly elevated serum beta HCG titers, a reliable tumor marker. It has a high propensity for hematogenous dissemination. It has high cure rates with chemotherapy, about 90%. It is important to note that Markedly elevated HCG is a reliable marker of the disease. HCG levels reflect the tumor burden, therefore they are used for diagnosis, follow-up, evaluation of therapy response, and screening of recurrences. Histopathology is rarely obtained for diagnostic purposes. Clinical features. Vaginal bleeding is the most common symptom. Patients with untreated choriocarcinoma can present with metastatic disease, hematogenous spread, especially after non-molar pregnancies without uterine signs or symptoms. The most common metastatic sites are lung, more than 90%. The remainder are the liver, gastrointestinal tract, brain, spleen, and adrenals. Patients usually present with advanced disease at the time of diagnosis. Some patients with metastatic choriocarcinoma have no residual tumor in the uterus, most likely due to regression of the primary tumor. Some patients may be asymptomatic because the tumor is confined to the myometrium. Ultrasound. Here we see color Doppler ultrasound showing a hyper-echogenic heterogeneous uterine mass with increased peripheral vascularization. Here we see also power Doppler ultrasound showing a hyper-echogenic heterogeneous uterine mass with increased vascularization. CT scan and chest X-ray. As we mentioned earlier, choriocarcinoma has a high propensity for hematogenous dissemination. Here we see brain CT scan with multiple hyper-dense masses in the left hemisphere with midline shift. Here we see chest CT scan with two large rounded masses in the periphery of the left lung. Chest X-ray of a patient with choriocarcinoma showing multiple lung metastases. Gross appearance. Uterine lesions of choriocarcinoma range from microscopic foci to huge necrotic and hemorrhagic tumors. Here we see that the tumors are typically red to brown and fleshy due to its vascularity with extensive hemorrhage, necrosis, and destructive myometrial invasion. Here we see gross image of a hysterectomy with a large intrauterine heterogeneous dark red friable tumor occupying the entire endometrial cavity. Here we see a gross image of a hysterectomy with a large intrauterine dark red friable tumor involving the cervix and occupying the entire endometrial cavity and endocervical canal. Here we see two photos showing a superficial intrauterine polypoid tan red friable tumor in the endomyometrial portion. Here we see gross image of a salpingectomy showing a heterogeneous friable tumor that was ruptured during the procedure. Intraplacental choriocarcinoma can be a subtle lesion, grossly, and found only microscopically. That is a small incidental finding. It is commonly mistaken for placental infarct and typically small, less than 3 cm. However, placental nodule can be seen. Here we see placental node measuring 4 by 3 centimeters, surrounded by necrotic tissue. Pure choriocarcinoma of the testis is rare, accounting for only 0.3% of testicular germ cell tumors. However, it is more frequently seen as a component of mixed germ cell tumor, 15% of the cases. Coriocarcinoma of the testis is a malignant germ cell tumor that shows trophoblastic differentiation and resembles extraembryonic chorion. Here we see choriocarcinoma of the testis, which is a soft, friable tumor with extensive areas of hemorrhage and necrosis. Here we see multiple hemorrhagic nodules of choriocarcinoma metastatic to liver. These are autopsy specimens. Microscopic features. The main diagnostic features are an absence of chorionic villi, a trimorphic population of trophoblastic cells, large zones of hemorrhage and coagulative necrosis, a trimorphic pattern of syncytial trophoblastic cells, nests or sheets of mononucleate trophoblasts that include cytotrophoblastic cells, intermediate trophoblastic cells. The cytotrophoblasts are small and have clear or light pink cytoplasm, distinct cell borders, irregular nuclei, prominent nucleoli, and brisk mitotic activity. Compared to cytotrophoblast, intermediate trophoblastic cells are larger with more abundant cytoplasm and have more pleomorphic nuclei. The syncytial trophoblasts are large cells with abundant, deeply eosinophilic cytoplasm and one or more nuclei with dark, smudgy chromatin. They have spindle or elongated cytoplasmic extensions that surround clusters of cytoblasts or percolate within them. Here we see islands of viable tumor surrounded by large zones of hemorrhage and coagulative necrosis. These two features are typical in choriocarcinomas. Coriocarcinoma has a distinctive biphasic appearance consisting of mononucleated trophoblastic cells, including cytotrophoblastic cells and intermediate trophoblastic cells. They are closely associated with and capped by a multinucleated syncytial trophoblast in a hemorrhagic background. These images show classic biphasic appearance in a choriocarcinoma consisting of mononucleated trophoblastic cells with clear cytoplasm closely associated with and capped by multinucleated syncytial trophoblasts with deeply eosinophilic cytoplasm. The mononucleated trophoblastic cells include numerous smaller cytotrophoblasts and scant numbers of larger intermediate trophoblasts. These images show a sheet of intermediate trophoblasts on the right and several syncytial trophoblasts with smudgy nuclei on the left. Here we see gestational choriocarcinoma with atypical trophoblastic cells and increased mitotic activity. The image shows metastatic choriocarcinoma in the lung. Here we see on the left side the alveolar spaces. This focus shows aggregates of large mononucleated trophoblastic cells and a few syncytial trophoblastic cells. Coriocarcinoma has a propensity for early metastasis via hematogenous route. Patients usually have advanced disease at the time of presentation. The most common metastatic sites are lung in more than 90%, the remainder are liver, gastrointestinal tract, brain, spleen, and adrenals. Please note that chorionic villi are absent except in rare choriocarcinomas associated with the hyalinized villi of a remote pregnancy. Rare choriocarcinomas arising in a term placenta. In the latter situation, the lesion may consist of a centrally necrotic zone or composed of infarcted villi surrounded by viable choriocarcinoma within the intervillous spaces. Immunohistochemistry of choriocarcinoma. Beta human chorionic gonadotrophin immunohistochemical staining showing strong positive cytoplasmic staining in choriocarcinoma components, syncytial trophoblasts, and large mononucleated trophoblastic cells. Syncytial trophoblasts express HCG, human placental lactogen, inhibin, and glypican 3. Behavior of choriocarcinoma. Overall, post-chemotherapy survival is about 90%. Virtually 100% remission is expected if a tumor is localized. Death is usually due to hemorrhagic events within the metastasis or from pulmonary insufficiency, tumor burden, or effects of treatment. Coriocarcinoma arising in term placentas may have an eventful course or be associated with metastatic disease in the mother or infant. Prognostic factors of poorer outcome. Older age arising from a non-molar pregnancy, long interval between index pregnancy and diagnosis, markedly elevated HCG, large tumor burden, metastasis to brain and liver, chemo resistance. Lesions of intermediate trophoblast. It is important to remember that there are three subpopulations of intermediate trophoblast with distinctive morphological and immunohistochemical features. They include villous intermediate trophoblastic cells, implantation site intermediate trophoblast, chorionic type intermediate trophoblast. The lesional cells of exaggerated placental site and its neoblastic counterpart, placental site trophoblastic tumor, are derived from implantation site intermediate trophoblast, whereas placental site nodule and its neoblastic counterpart, epithelioid trophoblastic tumor, are derived from chorionic type intermediate trophoblast. Markers of implantation site intermediate trophoblast are HPL, human placental lactogen, and MELCAM CD 146. Markers of chorionic type intermediate trophoblast are CK, EMA, P63, CD10, and inhibin alpha. Epithelioid trophoblastic tumor. Definition and general background. Trophoblastic tumor. It is a trophoblastic tumor of neoblastic chorionic type intermediate trophoblast. It is a rare type of gestational trophoblastic disease with only 110 case reports in the literature, and most of the studies are case reports. It usually occurs in the reproductive age range, 15 to 48 years. The epithelioid trophoblastic tumor is preceded by a term gestation in 2/3 of cases with spontaneous abortions and hydatidity form moles being the antecedent gestation in the remaining cases. Usually there is a long interval following the gestation, and the diagnosis of this tumor is a range of 1 to 18 years, average 6.2 years. Abnormal vaginal bleeding is the most common clinical presentation. Serum beta HCG levels are usually elevated at the time of diagnosis, although the levels are generally low, less than 2,500 MIU per ml. The primary tumor most commonly occurs in the endometrium, but can sometimes be centered in the uterine cervix, develop outside the uterus in places such as the broad ligament, or even present as a primary lung tumor. Gross appearance of epithelioid trophoblastic tumor. Epithelioid trophoblastic tumor presenting as a well-circumscribed tumor in the lower uterine segment. In half of the cases, it arises from the lower uterine segment or cervix and have overlapping morphologic features with squamous cell carcinoma. Microscopic features of epithelioid trophoblastic tumor. Epithelioid trophoblastic tumor, it lacks the trimorphic pattern of choriocarcinoma. It is composed of chorionic type intermediate trophoblast. It shows abundant apoptotic cells and islands of necrotic debris in most tumors. The tumor invades in an expansile fashion. It shows expression of P63 and the trophoblastic markers HSD3B1 and HLA-G. It has Ki67 proliferative index of 10 to 25% with a mean of about 20%. Here we see nests of viable mononucleate intermediate trophoblasts surrounded by extensive necrosis, hyaline-like matrix resembling keratinous material in squamous cell carcinoma. Here we see the tumor is composed of a population of relatively uniform polygonal mononucleate trophoblastic cells of chorionic type intermediate trophoblast. Necrosis is a common feature of epithelioid trophoblastic tumor. The tumor lacks the trimorphic pattern of cytotrophoblast, intermediate trophoblast, and syncytial trophoblast of choriocarcinoma. Here we see low magnification view showing extensive areas of necrosis with several irregular islands of tumor cells in a hyaline matrix surrounding small blood vessels that is very vascular fashion. Epithelioid trophoblastic tumors do not infiltrate and replace the vascular wall, unlike the trophoblast at the early implantation site and in post-placental site trophoblastic tumor. In half of the cases, epithelioid trophoblastic tumor arises from the lower uterine segment or cervix and has overlapping morphologic features with squamous cell carcinoma. Here in this photo we see two nests of tumor containing central eosinophilic hyaline necrotic material, an appearance that can be mistaken for keratinizing squamous cell carcinoma. The microscopic appearance closely simulates carcinoma of either squamous or glassy cell type. A theorem of lymphocytic infiltrate is occasionally found at the periphery of the expansile masses, similar to placental site nodules. A unique feature of epithelioid trophoblastic tumor compared with placental site trophoblastic tumor and choriocarcinoma is its ability to replace and re-epithelialize the endocervical and or endometrial surface epithelium. Here we see epithelioid trophoblastic tumor replacing and re-epithelialization epithelizing the endocervical glandular epithelium. A metastatic epithelioid trophoblastic tumor in the lung. The tumor exhibits a well circumscribed border with intense inflammatory infiltrate. Differential diagnosis of epithelioid trophoblastic tumor. In contrast to choriocarcinoma, epithelioid trophoblastic tumor does not have a trimorphic pattern with interspersed syncytial trophoblastic cells. It is not as hemorrhagic as choriocarcinoma. Immunohistochemically, epithelioid trophoblastic tumor shows only random beta HCG reactivity, in contrast to abundant staining of syncytial trophoblastic cells in choriocarcinoma. Squamous cell carcinoma is the differential diagnosis because of epithelioid trophoblastic tumors' frequent location in the cervix, squamoid appearance of their cells, keratin-like hyaline necrotic material, high-grade squamous intraepithelial lesion like endocervical gland involvement. Features favoring or indicating squamous cell carcinoma include abnormal serum HCG, overt squamous differentiation that is presence of keratin, bona fide HSIL, reactivity for P16 and CK5-6, negativity for trophoblastic markers such as inhibin, HLA-G, HPL, and HCG. Placental site trophoblastic tumors have a more diffuse infiltrative myoinvasive pattern. However, the epithelioid trophoblastic tumors have nodular growth pattern with the distinctive hyaline matrix. A more sheet-like growth versus nest and cord of epithelioid trophoblastic tumor. Larger cells with more nuclear polymorphism and multinucleation. Prominent and distinctive vascular invasion. Strong diffuse staining for human placental lactogen and MELCAM CD146. Epithelioid trophoblastic tumor has only limited reactivity for HPL and MELCAM. Negative staining for P63. P63 reacts with chorionic type intermediate trophoblast that comprises epithelioid trophoblastic tumor. Behavior and treatment of epithelioid trophoblastic tumors. It behaves as a malignant tumor with metastasis to lung and other sites. Extrauterine spread is usually blood-borne, but rarely to pelvic lymph nodes. Metastases occur in 25% of cases and 10% die of the disease. Response to chemotherapy is variable. Survival is 100% when confined to the uterus, but decreases to 50 to 60% in patients with metastasis. Stage 1 disease is treated with hysterectomy. Metastatic disease is treated with surgery and chemotherapy. Placental site trophoblastic tumor. Definition and general background. It is a very rare form of trophoblastic neoplasia composed predominantly of implantation site intermediate trophoblasts that invade normal tissues. Its incidence is approximately 1 per 100,000 pregnancies and about 1 to 2% of all the gestational trophoblastic neoplasia. Its mortality rate is 25%. There is usually a history of an antecedent normal pregnancy or a non-molar abortion, with a median interval from the last non-gestation of 18 months. Placental site trophoblastic tumors appear to always contain a paternal X chromosome, that is, are always preceded by a female gestation. In other words, it has a constant XX genome. The most common presenting symptoms of placental site tumor are vaginal bleeding and amenorrhea. The beta HCG titer is generally low. Expression of human placental lactogen is increased on histologic section as well as in the serum. Because placental site tumors extensively infiltrate the myometrium, the uterus can be perforated during curettage. Unlike most forms of gestational trophoblastic disease, the tumor is not very responsive to chemotherapy. Gross appearance. The section surface shows a focally hemorrhagic mass invading the myometrium. Microscopic features of placental site trophoblastic tumor. Here we see sheets and clusters of tumor cells with typical abundant amphiphilic cytoplasm invading and dissecting between the myometrial smooth muscles. The tumor cells are focally separated by fibrinoid deposits. The tumor cells fill the lumen of a myometrial vessel, the wall of which has been replaced by fibrin. Most cells have a single irregular and hyperchromatic nuclei, but binucleate and multinucleate intermediate trophoblastic cells are also present. The cells are pleomorphic with moderate to marked variation in nuclear size and shape, often a feature of the tumor. A mitotic rate of 0 to 20 mitotic figure by 10 high power field, mean 5 atypical mitoses are common. In the center, the intermediate trophoblastic infiltrate and replace the wall of a blood vessel while preserving the lumen. In placental site trophoblastic tumor, there is a characteristic pattern of vascular invasion, in which the intermediate trophoblast surrounds and replaces the vessel wall while retaining its overall structure and integrity. In this field, the intermediate trophoblastic cells is starting to invade a blood vessel wall left of center. Early stage vessel involvement. In this field, the trophoblastic cells have invaded blood vessels and protrude into the lumen. This is mid-stage vessel involvement. Eosinophilic fibrinoid material deposits are seen in the blood vessel wall. Late stage vessel involvement. A blood vessel wall replaced by eosinophilic fibrin resulting in an intact flaccid lumen. Monotonous trophoblastic cells surround the blood vessels. Here in this photo, the tumor is composed of a monomorphic population of intermediate trophoblastic cells with hyperchromatic irregular nuclei and a moderate amount of eosinophilic cytoplasm. Extracellular bright pink eosinophilic fibrinoid material surrounds the cells in an haphazard fashion. Immunohistochemistry of placental site trophoblastic tumor. In placental site trophoblastic tumor, the intermediate trophoblastic cells are diffusely immunoreactive for HSD3B1, HLA-G, HPL, and MELCAM, which is CD146, as well as inhibin alpha. Here we see that tumor cells are immunoreactive for human placental lactogen, HPL. Here we see that tumor cells are immunoreactive for inhibin alpha. In this tumor, HCG staining is negative, P63 is negative, and the Ki67 index is typically more than 1%. Behavior and treatment of placental site trophoblastic tumor. These neoplasms are usually benign despite destructive growth in the myometrium. About 15% show aggressive malignant behavior with disseminated metastasis. Most clinically, tumors are associated with one or more adverse prognostic factors, including an age more than 35 years, interval since the last pregnancy of more than 2 years, previous term birth versus other type of antecedent pregnancy, myometrial invasion beyond the inner 1/3, stage 3 or 4, maximum HCG level more than 1000 mill international unit per ml, extensive necrosis, more than 5 mitotic figure per 10 high power field, tumor cells with clear cytoplasm. The standard treatment is surgery, including total hysterectomy with or without bilateral salpingo-oophorectomy. Patients with high risk factors require adjuvant chemotherapy. The prognosis of placental site trophoblastic tumor is good if it is limited to the uterus, and in contrast to the mortality can reach up to 25% if metastases occur. Non-neoblastic trophoblastic lesions. They include exaggerated placental site nodule and blood, exaggerated placental site. Definition and general background. An exaggerated placental site represents one end of the morphologic spectrum of the normal implantation site. Synonymous terms have included syncytial endometritis and exaggerated placental site reaction. It is not a tumor. It is an unusually prominent but physiologic placental site. The exaggerated placental site is characterized by an increase in the number and size of individual intermediate trophoblastic cells with widely dispersed multinucleated intermediate cells, trophoblastic cells. It is not genetically related to the placental site trophoblastic tumor, so it is lacking the latter's constant XX genome. It may be difficult to distinguish from a placental site trophoblastic tumor. Exaggerated placental site is assumed to regress spontaneously and has not been associated with any adverse sequelae. It has no clinical significance. Microscopic features of exaggerated placental site. Here we see there is striking involvement of the myometrium by intermediate trophoblasts, and the cells are usually disposed singly or in small nests. Compared to the normal implantation site, the intermediate trophoblastic cells within the endometrium and superficial myometrium are increased in number and often show unusual degrees of nuclear atypia and multinucleation. Many multinucleated intermediate trophoblastic cells are present. Necrosis and mitotic activity are absent. In the exaggerated placental site, the intermediate trophoblastic cells appear larger and more hyperchromatic than normal. Despite their apparent prominence, these intermediate trophoblastic cells show no mitotic activity. Here we see intermediate trophoblastic cells are positive for human placental lactogen, HPL. The cells are negative for P63 in the extravillous trophoblast as compared to P63 positive villous trophoblast. Here we see abundant trophoblastic cells which are present at the implantation site. A dual immunohistochemical stain for HLA-G, they are red, and Ki67 brown, demonstrate no proliferative activity in the trophoblastic cells. The Ki67 is staining infiltrating lymphocytes and not the trophoblastic cells. Ki67 immunostaining is 0 when the exaggerated implantation site is associated with an abortus. However, it can be slightly elevated when it is associated with a complete hydatidiform mole. Differential diagnosis of exaggerated placental site. The differential diagnosis is mainly with the placental site trophoblastic tumor. Features favoring placental site trophoblastic tumor are absence of a recent pregnancy, presence of a mass, presence of confluent aggregates of mitotically active cells, destructive myoinvasion, presence of necrosis, Ki67 index of more than 10%, constant presence of XX genome. However, the nuclear tibia is not helpful as it is striking in exaggerated placental site. The presence of decidual alveoli and low Ki67 index less than 1% favor exaggerated placental sites. Placental site nodules and plugs. Definition and general background. A placental site nodule or plug is a well-circumscribed hyalinized lesion composed of chorionic type intermediate trophoblastic cells that are normally located in chorion leaf or fetal membrane. Typically, it is incidentally found in an endometrial biopsy, endocervical curating, or cervical biopsy from a woman in the reproductive age group. Very rarely, placental site nodules can be found in fallopian tubes, presumably after a tubal ligation for several years. They occasionally are discovered in the early post-menopausal years. They are non-neoblastic. They have an eventful follow-up and no malignant potential. That is, placental site nodules behave in a benign fashion. Neither local recurrence nor metastasis have been reported in patients treated by either hysterectomy or curettage or alone. No specific treatment or follow-up is necessary for this lesion. The placental site nodule is a small, often microscopic finding. When grossly visible, it presents as a yellow, tan, or hemorrhagic nodule measuring up to 1 centimeter in diameter and located in the endometrium or superficial myometrium. Not well circumscribed border and extensive hyalinization. The trophoblastic cells contain cytoplasmic vacuoles, eosinophilic hyaline bodies, and have hyperchromatic nuclei that vary considerably in size and shape. A placental site nodule in endometrium curettage samples showing the typical nodular and hyalinized appearance of the lesion at low magnification. High power magnification of a placental site nodule demonstrates hyalinized extracellular matrix with a cluster of hyperchromatic and vacuolated chorionic type intermediate trophoblastic cells, haphazardly distributed. A benign endometrial gland can be seen on the top left. Here, we can see this here. A typical placental site nodule plug. It is a placental site nodule with moderate to severe atipia and Ki67 proliferation index 8 to 10%. These lesions may represent a transition from benign placental site nodule to epithelioid trophoblastic tumor. The behavior of a typical placental site nodule has not yet been studied. Differential diagnosis of placental site nodule plug. Placental site nodule, in contrast to epithelioid trophoblastic tumors, are usually microscopic, paucicellular, diffusely hyalinized, composed of mitotically inactive cells with a degenerative appearance, negative for cyclin E, and have a low Ki67 index. The second one is hyalinizing squamous cell carcinoma. Features indicating a placental site nodule. Blood include circumscription, mitotic inactivity, and absence of squamous differentiation, positivity for CD10 inhibin, alpha and CK18. Ki67 index is of less than 5%, negativity for P16. Trophogram. Trophogram is an immunohistochemistry-based approach that combines a set of trophoblast-associated markers to facilitate the diagnosis of trophoblastic tumors and tumor-like lesions, including exaggerated placental site, placental site trophoblastic tumor, placental site nodule, epithelioid trophoblastic tumor, choriocarcinoma. It is a three-tiered sequential staining procedure that uses the panel of commercially available antibodies. The first tier is to discriminate a trophoblastic versus a non-trophoblastic lesion. The second tier is to determine whether the lesion is a choriocarcinoma, a lesion related to implantation site intermediate trophoblast, or a lesion related to a chorionic type intermediate trophoblastic cells. The third tier is to distinguish a benign tumor-like trophoblastic lesion versus a true trophoblastic neoplasm. Suspicious for trophoblastic lesion, we use a trophoblastic marker HSCD3B1 and CK18. When they are positive, it means that it is a trophoblastic lesion. We use P63 and HPL when P63 is negative and HPL positive. It means lesions of implantation site intermediate trophoblast. When it is P63 positive and HPL negative or positive, it means lesions of chorionic type intermediate trophoblast. PHCG positive syncytial trophoblast, it means that it is choriocarcinoma. In the cases of lesion of implantation site intermediate trophoblast, if the Ki67 less than 1%, it means that it is exaggerated placental site. However, if the Ki67 more than 8%, it means that it is placental site trophoblastic tumor. In cases of lesions of chorionic type intermediate trophoblast, if the Ki67 less than 5% and cyclin E negative, it means that it is placental site nodule. However, if Ki67 more than 15% and cyclin E positive, it means that it is epithelioid trophoblastic tumor. FIGO staging of gestational trophoblastic disease. Stage 1, tumor confined to the uterus. Stage 2, tumor extends by metastasis or direct extension to other genital structures, including vagina, ovaries, broad ligament, or fallopian tubes, that is limited to genital structures. Stage 3, metastasis to the lungs. Stage 4, other distant metastasis with or without lung involvement. FIGO stages are subdivided into A, no risk factors, B, one risk factor, C, two risk factors. The risk factors are serum HCG more than 100,000 international unit per milliliter, or duration of disease more than 60 months from termination of antecedent pregnancy. Here are the references. Thank you.